Good afternoon and welcome to the 2015 Robert S. Gordon Jr. Lecture in Epidemiology. I'm sorry that the President was not able to stay over and introduce our speaker today. He spoke here yesterday at about 5 o'clock, but it was unable to stay. My name is David Murray. I'm the Associate Director for Prevention and Director of the Office of Disease Prevention. I'm very pleased to represent Dr. Collins today and introduce our speaker. I wanted to say a few words about Robert Gordon and the Robert S. Gordon Lecture Award. This lecture is awarded each year to a scientist who's made major contributions in research or training in the field of epidemiology or in the conduct of clinical trials. The Gordon Lecture Award recipient is selected based on recommendations of the NIH Epidemiology and Clinical Trials Interest Group. This is the 21st year that my office, the Office of Disease Prevention, has been involved in the lecture and has sponsored it. The list of very prominent scientists who have received this award previously is available on our website, where you can take a look at it. The Gordon Lecture Award was established in tribute to Robert S. Gordon Jr. for his dedication to the field of epidemiology and his distinguished service to NIH. He worked here for more than 30 years. He served in numerous senior leadership positions, including Special Assistant to the Director and Chief Advisor for Clinical Practice and Research. Dr. Gordon was an early organizer of efforts to address the emerging problem of HIV and AIDS, and became a key coordinator of AIDS research on the NIH campus. For the last 10 years of his service here, Dr. Gordon made important contributions to policy and management issues regarding epidemiology, clinical trials, and health effects of environmental hazards. So we're grateful for all that he has done, and this award is in his honor. It's a very great pleasure for me to introduce this year's Gordon Lecture Award recipient, Dr. Shariki Kumanyika. Dr. Kumanyika received her PhD in human nutrition from Cornell University in 1978. She obtained her master's in public health degree from the Johns Hopkins University in 1984. She went directly to join the faculty as assistant professor, first at Cornell, then at Johns Hopkins, then at Pennsylvania State University, then at the University of Illinois, Chicago. Dr. Kumanyika has moved around a little bit. She joined the faculty as professor of epidemiology at the University of Pennsylvania in 1999 and retired just this summer, having served as professor of epidemiology and associate dean for health promotion and disease prevention in the School of Medicine. Dr. Kumanyika's research has focused on ways to reduce diet-related chronic disease risks, particularly among African Americans. She has served as principal investigator or co-investigator for many multi-center and single-center randomized clinical trials or observational studies related to salt intake, other aspects of dietary intake, and of course obesity. Several of her studies have examined ways to promote healthy eating and physical activity in African American children or adults in clinical and community-based settings. She founded and continues to chair the African American Collaborative Obesity Research Network, a national network that seeks to improve the quantity, quality, and effective translation of research on weight issues in African American communities. Dr. Kumanyika is an elected member of the Institute of Medicine, the American Epidemiological Society. She's a fellow of the American Heart Association, the American College of Epidemiology, and the Obesity Society. She is president-elect of the American Public Health Association. Dr. Kumanyika is the co-chair of the Institute of Medicine's Committee on Childhood Obesity Prevention and of the International Obesity Task Force. She's also a member of the World Health Organization's Nutrition Guidance Expert Advisory Committee. She was a member of the NHLBI Advisory Committee, or Advisory Council, from 1996 through 2000. She has served on the monitoring board of the Jackson Heart Study since 1998. I lost track of the number of NIH committees and work groups that she has participated in, simply too many to count, across a wide number of institutes and centers on this campus. She's published extensively in the peer-reviewed literature and published 2 books on obesity prevention. Her presentation today is entitled Research Directions for Solving the Obesity Epidemic in High-Risk Populations. There will be time for questions after her remarks. I would also like everyone to join us at a reception for Dr. Kumanika at the NIH Library, which is just across the hall to my left. And now please join me in welcoming the 2015 Robert S. Gordon Jr. Lecture Award recipient, Dr. Shariki Kumanika.
Good afternoon. Can you hear me okay? Good. Well, this is a delight. I am really pleased to be here. I don't know when I've looked forward so much to a talk. And I see a lot of familiar faces and colleagues I've worked with over the years in the audience. It's really an honor to be the awardee of this lectureship. I read a little bit about Robert Gordon and came away with the impression that he was a problem solver, and I identified with that sense of being a researcher, an advisor who really wants to use the science to solve problems. And I hope that what I say today will bring us a little bit closer to thinking about how to solve a somewhat intractable problem of obesity in high-risk populations using African American data as an example, but as an example of a way of thinking that might readily be applied to other high-risk populations. So I have framed this as a retrospective for about 10 years or more. Some of the reflections go back a little bit farther, but I thought, we could ask the question of where we were 10 years ago on the obesity research agenda. Where are we now in terms of high-risk populations, and where can we go? How will we get there to solve this problem? So I'm trying to be positive. You could look at this as a glass half empty or half full. We don't know a lot, but we do know a lot. And I'd like to invite you to think with me about what we do know and what it means. So where were we 10 years ago with obesity prevalence in black populations, and on this slide also Mexican Americans? If you look at the yellow bars, you can see that in the data point 1999 to 2004, about a third, 30% or a little more than that, of white men, black men, and Mexican American men were in the obese category, and in the women, about the same proportion in white women, but 54%, more than half of black women, and about 42% of Mexican American women were in the obese category. The other bars on this graph are straight line projections of what the rates of obesity would look like if they continued at the same rate as had been seen in the past data. So those are the dire projections of what might happen if we don't get a handle on this problem. The one that's most striking is 76% of black women by 2030 would be over BMI 30 or in the obese range. In children, fortunately the rates are lower in children, but still of concern. 17, 18, 19% of white boys, black boys, and white girls. More, 25%, the high-risk group in children has been in the Mexican American boys in these three groups. And in girls, it's the 27% that you see in the yellow bar in black girls. So that's where we were. Where the gray bar is where we don't want to be. And I'll show you later some data about where we are now. But to continue, I'd like to mention, David mentioned some of the committees I've been on. I had the opportunity to be involved in a lot of the agenda setting that was going on around 2003, 2004. And these are covers from the think tank report from part along the Enhancing Obesity Research at the National Heart, Lung, and Blood Institute, and the executive summary, which it turned out was about as long as the report because we just couldn't leave anything out. And then the NIH Obesity Research Agenda that was issued around that time and leading up to the one-stop shopping obesity research NIH.gov website. There were two aspects that came out of the think tank report. One was, and I have new in quotation marks because they weren't new in that nobody had ever mentioned them before, but they were more or less newly acknowledged as important threads in the obesity research agenda. One was the need for societal approaches involving environmental and policy changes to address obesity. And some of the recommendations had wording like, embrace the full power of the social sciences, work with researchers who understand the environment and some of the societal causes of obesity. And the other aspect that came out that was particularly important to me was the increased awareness of the need for solutions that were applicable to ethnic minority and other high-risk populations. At the time, the obesity research evidence was primarily on treatment-seeking populations with white women and then some related to populations with diabetes, but the public health need for addressing obesity in minority populations was not really acknowledged, and the clinical guidelines that had been released a few years prior basically said we're not sure what works in ethnic minority populations, although we think things might work differently, and here's some suggestions based on what people have been trying. So we really were at a point where we needed to bear down on this issue. I was especially pleased that something I had been working on before the obesity epidemic had emerged. I started in 1984 working on obesity in black women, which stood out as an issue at an NIH meeting I attended on coronary heart disease in blacks in 84 at one of the buildings on this campus. So it's just coincidence that that's about 30 years ago, maybe even to the day or around this time. And so I published this article in Epidemiologic Reviews in 1987, Obesity in Black Women, where I tried to figure out, is this really a problem and what could be causing it, and tried to rule out some explanations. And then later I published a review of obesity in minority populations more broadly, coming up with the finding that really this problem of excess weight gain and high rates of obesity was common to most of the ethnic minority populations in the U.S. I also looked at the issue in children in 1993, and some special issues related to attitudes and practices, also in 1993 from a consensus conference that was here at NIH. And in 1991, looked at the treatment side of things and learned it was kind of hard. I think this was when Bill Harlan was the head of the Office of Disease Prevention, really to get permission to look at clinical trial data separately by race, because I had a feeling that the interventions weren't working as well in the African American participants in the trials of hypertension prevention and the hypertension prevention trial. And when we did analyze the data that way, indeed the weight losses were less and the weight gain in the control group was more, suggesting a different background and a different treatment impact. In 2002, I needed a little help from my friends, so to speak, and I formed a research network that was mentioned, the African American Collaborative Obesity Research Network, to come together and create a research agenda specific to the black population. And I was really pleased that Claude L'Enfant, who was the director of the Heart, Lung, and Blood Institute at that time, permitted me, kind of as a trade-off, for me to co-chair the EpiTrack, co-chair that think tank in the EpiTrack with Claude Bouchard, who was doing the basic science track, and invite 10 African American scholars, most of whom would not have been invited to a meeting of that type, to listen and become a part of that I really increased the number of African American scholars there by an order of magnitude, I think, by inviting my group. And that was our start. We had a satellite CDC funded meeting at which we developed a research agenda that played off of the think tank recommendations. And in 2007 published a research paradigm that grew out of a CDC conference, and that's the main element that you see on this slide. And this research paradigm was related to the issue of societal causes. We called for mixed methods research, really using both quantitative and qualitative methods, and looking at, as you see the three circles in the Venn diagram, considering different environments, physical and economic environments, historical and social contexts, and cultural and psychosocial processes when considering interventions on energy balance, thinking about the issue in the population context instead of thinking about the, how to understand people starting with their energy balance and then working out from that. So we wanted to contextualize the research and make it more community focused, and have been using this paradigm to guide our work since then. So I've talked a little bit about where we were, 10 years ago and moving forward in this decade, and now I want to turn to where we are now. What has the evidence, the research that's been done, told us about this issue and how to address it? So the data slide gives prevalence levels, and I compared them with the projections in the graph that I showed you before. And for men, this 38% is about a little bit less than halfway between where we were back in 2004 and where we might have been where we might be in 2020. So it's on that trajectory. Obesity in black men was not something that people have talked about. So I want to just pause so that you understand that everything has been focused on women and girls in the black community, and while we were asleep at the wheel, the rates in black men began to increase, and the rates in black boys have begun to increase. So if you look at the 6 to 11-year-old boys, this 28% in black boys is higher than was projected for 2020 in that straight line projection before. And in adolescence, the difference between the white and the black boys appears to me to be a little less than was projected, so maybe there's been some progress in that age group, or maybe the white boys are catching up. Disparities can work both ways. The group that's better off can get worse, or the group that is worse off can get better, and we have to watch both of those when we look at the absolute levels. In females, black women are still much higher than white women, and somewhat higher than they were 10 years ago. And then you still see differences in the children, the 6 to 11-year-old girls. There's a difference of 25%, but not as high as one might have projected. That's a little lower than it was in the prior data set. So the rates have not gone down, and in males, they've actually gone up. Overall, the rates in black children and Hispanic children have increased more steeply at some periods during the epidemic. The epidemiology has also told us, besides that the higher risk in women predates the current epidemic, that the trends of increase are worse in some groups, and that the absolute prevalence is higher, that the prevalence of obesity-related disease is higher. There's less success in weight loss in the state-of-the-art trials. There's a higher risk for weight gain, even while in some of the trials, and higher risk for lower treatment impact, and a continuing uncertainty about the effectiveness of interventions. The other thing that, and it harks back to the finding in the think tank, that the environments for achieving and maintaining a healthy weight are more challenging because the context for healthy eating and active living are less favorable in black communities. Some of the data a combination of quantitative and qualitative data that have been pulled together to show what these environmental risks are in the physical, economic, and social cultural environments are shown here, both for food and for physical activity. You've probably heard some of these mentioned, especially the ones related to supermarkets, because we now have a federal initiative to put supermarkets, quality supermarkets, in communities that may have food stores, but don't necessarily have the kind of food stores where you could buy or where you would want to buy healthy food. More fast food restaurants, target marketing through many channels, including outdoor ads, media that come into the black community, and so forth, and less private transportation for food shopping, economic factors. I won't read through all of these, but I think you can scan them yourself and get the gist. Many things that would be supportive of healthy eating and physical activity are not there, and things that are unsupportive of healthy eating and physical activity are there. So our approach to looking at the evidence for on this issue was really centered around what do we know about how to intervene on the problem, because we're very solution-oriented. So the EPI has made us excellent at documenting the problem. No one's arguing anymore that the problem is there. There's some concerns about maybe the BMI doesn't work as well in different population groups, and for some purposes maybe it doesn't work as well, but the amount of excess weight that's there is not an artifact of BMI being the wrong measure, to be sure. And the health consequences going with it show that even if BMI isn't measuring body fat, it's measuring risk. So our assessment here took the form of 10 systematic reviews that were published in a special issue of Obesity Reviews, which is one of the journals of the World Obesity Federation. And it's published in a supplement in October 2014. It will be open access within the next month, I hope. Not quite yet. You need to go through library access. So the 10 systematic reviews are on different topics that relate to lifestyle behavior change, cultural adaptations, environmental and policy interventions, and I'm going to highlight some of the findings. 2 are on children, school, and after-school settings and out-of-school time, and then 1 is on physical activity, environmental and policy change, etc. So the overall findings about the evidence base on interventions on weight, nutrition, and physical activity that are relevant to black populations is on this slide. The first point, defining relevance to black populations, was not straightforward. Relevance is clear when the population targeted is 100 or 99% African American. For the rest of the studies, we started off ambitiously, well, relevance will be defined as 90% or more, because the 10% of people who are not African American wouldn't change the findings that much. Most of the authors of these reviews had to go as low as 50% to include articles that had some information about African Americans. And we also included studies where the number was large enough to do an analysis of a subgroup, and the subgroup was reported separately. So a targeted population, a subgroup analysis, which is risky methodologically because some of the subgroups were still pretty small, or 50, 60, 70, 80%, depending on the particular topic that was being addressed. So we found a whopping 171 studies. And most of the authors went back to the beginning of the database, to the beginning of PubMed or whatever they could find. Some restricted to the more recent literature, but there's a sense that if you doubled this, you would have definitely exceeded the number of studies there, because there weren't that many in the older part of the literature. 27 were cited in more than one paper, so there were really 140-some studies that we found. 6 to 28 per review, depending on the topic. So that's what we had to work with looking at interventions. The data were heterogeneous. There were many, many methodological limitations in the studies. Not all were controlled studies, but we were inclusive because we wanted to know everything possible, but evaluated accordingly. There were conceptual limitations, particularly insufficient use of relevant theories and frameworks. There were numerous pilot studies that didn't seem to result in full studies, and dropout rates high in many studies and incomplete follow-up data. So the first study to consider is one looking at what we consider the best case scenario. We know that a lot of African Americans have been involved in the multi-center trials of hypertension prevention, diabetes prevention. So we looked at this group led by Brooks Wingo and Jamie Ard's group, found 7 studies: the hypertension prevention trial, the 2 trials of hypertension prevention, TOHP1 and 2, Premier study, the DPP, the Diabetes Prevention Program, Look Ahead, and the trial of non-pharmacologic interventions in the elderly. These were funded by several of the institutes, and I was involved in some way in probably almost all of them. The average weight losses were less than in whites at 6 months compared to less than in whites at 6 months. And so the numbers are here. The range minus 1.6 to 7.5 kilograms versus 3.8 to 8.2 kilograms. And this is the initial weight loss that they found. So the 2 things you could take away here: one is that there was substantial weight loss in many of the black participants, but the other is that it wasn't as large as the weight loss that was observed in whites. The good news, I think, is that even though there are these differences in weight loss, and we don't understand either why the weight losses are less, we also don't understand why the risk factor outcomes seem to be just as good. So fortunately, that lower weight loss is giving benefit for blood pressure or diabetes control that seems to be comparable, with the exception that there was not blood pressure improvement in black women. The diabetes prevention program has been really a game changer for looking at what lifestyle intervention can do on weight loss. And so Carmen Samuel Hodge and colleagues at the University of North Carolina looked at the effectiveness of DPP translations in populations that included African Americans. They found 17 studies. 7 were 100% African Americans, and the others you could interpret the data in some way as relevant to African Americans. Relatively few of the studies were judged to be of high quality, although some were. And what they found, and you won't be able to read the legend here, but you can see the bars very clearly. So the line going across the top at around 6 kilograms is the weight loss achieved, about 6 kilograms, in the early phase of the DPP in the black participants. And the bars, the height of the heavy bars, is showing you what weight loss has been achieved in the translational studies that were done in various community or research settings outside of the strict high-cost efficacy circumstances of the DPP. So there's weight loss, but it's not as good, so we're losing the effect. The weight loss in blacks was less than in whites. The weight loss in translated DPP is about half in the highest quality studies of the weight loss that the blacks in the DPP had. So there's room for improvement here, but it is encouraging that we're on the way to success with a proven method. We had one review on e-health interventions for 2 reasons. One is that minority populations are heavy users, perhaps heavier than average, especially young people, but also people of all ages. It's kind of against that idea of the digital divide. Digital media of some types are really being used very heavily in ethnic minority populations, and the e-health interventions are showing efficacy for weight loss in the populations where they've been studied. So Gary Bennett led this review, expanded it in order to have some studies to any ethnic minority population. So there was at least one study in there for Latino populations, and found only six studies. They were pretty good studies, and they were suggestive of short-term efficacy. There was no evidence on mobile approaches, and they may be the most heavily used, but it's very promising that a medium where you can reach minority populations is associated with an effective type of intervention. Another group from Marion Fitzgibbon's group in Chicago did a systematic review of culturally adapted strategies, because the message has been what's missing from the efficacy or effectiveness of weight loss must be that we haven't tailored this properly for the social cultural context in which weight loss is being attempted in black populations. And so they analyzed, limiting this to black women where most of the studies existed, this what people had done according to a typology of Matt Kruder, similar to a typology of surface structure and deep structure by Ken Resnick, and classified the type of cultural adaptation in terms of whether it was on the surface, whether it was trying to deal more with deep structure, involving constituents in talking about their culture and their circumstances, and then using that to develop the intervention. Evidential, providing evidence about the risk and so forth. Social cultural, relating attitudes and practices, and linguistic, changing language, which is less relevant to African Americans than Latinos, for example, and then targeting the group versus instead or also tailoring to individuals. So that was assessed, and they had 28 studies that they could evaluate. 17 reported some significant improvement in diet or weight outcomes. And the strategies that were the most common were the social cultural and the constituent involving, but there was no evidence on whether it was the cultural adaptation that was associated with the results, because we don't have head-to-head comparisons of an adapted study or a study where something was done specifically to adjust the cultural context, and the studies that didn't. So when you compare results in cultural adaptive studies, I'm not going to show you those data, but if you go back to the paper on NIH multi-center trials, the weight losses in a lot of the cultural adaptive studies might be significant or promising, but they may be smaller than in non-adaptive studies. And so we really don't have a science of cultural adaptation. We're not even near there yet, and there's not much standardization in what people are doing and calling cultural adaptation. One form of cultural adaptation is to put the intervention in a faith setting, and so one of our reviews looked at faith-based interventions. All of the interventions identified were in churches, that we had no interventions in mosques or other faith institutions, although not all African Americans are in Christian churches, but the studies that we found that were published were in churches, and 12 were RCTs, 10 were pilot studies, including some of the RCTs, I think, and 7 of these studies reported a change in something. Again, this is liberal, adhering to systematic review, but being very liberal in looking for positive signs that something is working. Now I want to turn to environmental and policy change interventions, because that is the area which has really been the new frontier for all of obesity research, and it's very important because of the differences in environments when thinking about African Americans. Our review of this area took advantage of a data set that was used to develop an evidence rating system by Laura Brennan and the Transtria group. And it was they put together 600 articles from 396 sets of studies that they call study groupings. So we took this database that they had created, it only went up to 2009, and looked to see of the effective nutrition strategies that they had rated, where did we have any data relevant to African Americans? And so they were looking at both internal and external validity because they really wanted to see how do you evaluate studies for reach, effectiveness, and so forth. So this is a list of some of the types of effective interventions that were in this database. Fewer in the nutrition-related category were considered effective, meaning had been studied or reviewed by a consensus group or were studied by Brennan's group to assess them as effective. More in the physical activity area involving street design, school policies, and so forth. So there were 142 intervention evaluations in this data set and 254 cross-sectional studies. If you want to, you can just put aside the cross-sectional studies because you can't really tell anything about people's reaction to the environment if you're studying them both at the same time. It's really the evaluation studies of the influence of the environment or the policy on behavior that we need. 33 of these were relevant, defined as I had mentioned before, to black populations. Some of them you couldn't tell who was in the population they sampled. And they related to 15 of these 24 strategies. For the evaluation studies, there were 10 out of this data set that were relevant. And the only clear finding in this was that child care settings, which include school, are the place to be with these interventions. No matter what type of study you had, you got a sense that if you could do something well in a child care setting, you could influence physical activity or weight. We did not have any really meaningful findings on nutrition in that regard. So the conclusions related to environmental and policy change were a whole methodologic study in and of themselves. One is to increase the priority to these, given to these evaluation studies, including the nutrition interventions and some of the promising or emerging strategies that are not yet rated effective, but they have some face validity and should be looked at. Certainly make reporting of the ethnic composition of the sample routine, because you can have a policy or an environmental intervention, and if you don't know which people are being reached by that, you can't tell that it's actually going to address a disparity or reach a high-risk population. And it could be that a high-risk population in a neighborhood or community is not going to have the same uptake of that intervention as people who have a different situation. Oversampling high-risk populations is probably a good idea. Gender-specific analysis, because girls and boys, this was childhood-focused, girls and boys don't react to their environments in the same way. They have different attitudes, issues, responsibilities, and social norms. We need to also compare, as I mentioned, the high and the low-risk groups to see if they're taking it up at the same level. Again, no conceptual frameworks related to how should this affect disparities, really rise up from looking at this. And so, theoretical frameworks are always useful in deciding, in designing studies. And then systems-oriented analyses, because all of these are complex. So when you pick out an intervention in an environment that's complex, and you look at it and you say it works or it doesn't work, it's going to be misleading if you don't know what else is going on in that same situation that's needed to make it work or that's keeping it from working. So the final question, where can we go? Let's look forward. How will we get there? We had, from our systematic reviews, 3 recommendations. I suppose they're recommendations to anyone who will listen, anyone who has funds. Not only NIH, but people who want to support research in this area about what to do and how to do it as we assess from our examination of these studies. Increase the quantity of high-impact obesity-related intervention research with black populations. And every word in that is probably an important operator. So high impact we decided would be the potential to have a decent effect size in a large number of people. It's feasible to do in an urban or a rural community, and it's potentially sustainable. We know what some possible high impact areas are. If we could take these topic areas that I've just talked about and work them up and have a concentrated programs of research to maximize school and child care. I added work sites because I think work site interventions have been shown to be effective in adults, and there's no reason they shouldn't be worked up for work sites that have high proportions of black adults. Faith-based settings, take these threads and work them up into high quality research and look for sustainability and scalability. The second recommendation is to support the research infrastructure that would make the first recommendation possible. So who's going to do this research? Where is it going to be done? Who's going to step up to the plate tomorrow and say, I want to contribute to a systematic, focused program of research on this population? You know, we have research and programs that focus on individuals, individual trainees. We have research that focuses on individual diseases, but we don't have enough research that focuses on the population to make sure that things add up. And I think what I'm saying now is that when we look at the data, it's not going to add up unless there's a concerted effort. So whatever mechanisms are available, create synergies, attract the scholars to centers, for example. The research should be interdisciplinary, should be linked to community organizations. That's essential because it has to happen in communities. Provide a context for conducting pilot studies so that if a pilot study is conducted, it goes somewhere. It's not just a person in an isolated institution who, when the results are equivocal, just drops that topic and goes on to something else. Training and methodology and development and training in methodologies that are needed, and perhaps cooperative agreements to ensure accountability and dissemination. The third recommendation has to do with standards and training programs about how to do good research and make sure that the effects are not diluted because they're either not sound, it's not relevant to the population, and so forth. So what would it look like if there was a handbook that people had to follow before they could get a grant to do studies in a population that's understudied and for which resources are limited to do these studies, so you don't want to waste anything. You only want to do research that's guaranteed to be tracked into a high quality pool of data. Some of the things that you might have for such a set of standards are listed here. They echo some of the things we've said before about the need for conceptual frameworks, methodological guidelines, adequate sampling and recruitment, innovative study designs, and no double standards. Because you're doing a study in a minority population, that doesn't mean it's the study that should be done. To hold people to account for how these studies are being designed and interpreted. So this is my last slide of overall conclusions and implications, and these are themes that I hope I've been presenting all along. We need focused research on this topic in Black Americans and, by extension, other high-risk populations, and we need it urgently because we're on that track that I showed you in that first slide. I mean, we're not going up in a steep linear fashion, but it doesn't look like whatever we've learned is reaching the Black community to the extent that it should. And I didn't show you data, but the data on the progress that we're making on the obesity epidemic is often showing exceptions when you look at the data for Black children or Black adults. They may not be getting the effect to the same level, and even still, we'd be plateauing at a very, very high absolute level of obesity in the Black population, in women and with men and boys still going up. The second conclusion, that the evidence base is limited currently in quality and quantity, and it's not going to converge if we keep leaving it up to an individual investigator to pick out a topic, do a study, publish it over here, and somebody else is doing something over here. It's just not converging. I've been looking at this literature now for 30 years. It's not converging, so we need to help it along to maximize the use of our resources. The third point is the fact that if we don't improve the methodology, the evidence that we get won't be useful. And that's especially risky when we're doing systematic reviews, and they tend to be the order of the day, but a systematic review is only as good as the evidence that you have to put into it. And the kind of compromises we had to make in doing our reviews, you shouldn't have to make for evidence that is appropriate for systematic reviews. So we really need to improve the methodological standards. And finally, and this may be my most radical point, I sneaked it, put it in here at the end, the research on environmental and policy interventions, it needs higher priority and continued expansion into new domains. And the ones I mentioned here, consumer behavior, I've been studying food marketing and food prices, which I never thought I'd be studying, communications and how people are hearing and what they're saying in terms of messages, and business and finance. And I leave you with that thought as we go into Q&A, because at the Public Health Association meeting a couple of weeks ago, it turns out that solutions in communities are coming much more aggressively from the business and finance communities than from the public health community. The Federal Reserve Bank, other kinds of financing mechanisms are coming forward to put into communities the things that they need to prevent and control this condition. And I think that we need to understand how our biomedical public health solutions dovetail with things that are coming from these other sectors so that the benefit reaches the community. Thank you. So I have 11 minutes for questions. Okay.
I was interested in suggestions that you might have to those of us here about things that NIH can do to improve the quality of the methods that are used in these kinds of studies.
Can you repeat the question for the
Okay,
people on
yeah.
video cast? If she can, or you wanted to do it in here, okay.
My question is, what suggestions do you have for us about things that we can do that would improve the quality of the methods that are used in these kinds of studies? It's something that lots of us talk about, but do you have specific suggestions for things we can do?
I'm sure I haven't thought about that enough, but I do think that many areas in this type of research, we have excellent methods that have been developed by some of the best researchers in the business of preventing and treating obesity. So it's a matter of disseminating information about methods so that investigators who may be isolated, they're not in sort of large heavy hitter groups, will see what the methods are and be able to afford them. There may be some support needed. Some people don't use accelerometers to measure physical activity because they're too expensive. And then you get a whole study done with a measurement that's not state-of-the-art, and then nobody believes the data. So we should find a way to make sure people have the equipment, but also that they know whatever clearinghouses that we might have, they know the what's considered to be the state-of-the-art methods, and use some similar methods across studies so that you can compare the studies. That's simple without developing new methods, and then there are areas, of course, where we need new methods. Dietary assessment in young children is one where I'm not sure that when people are choosing methods, they understand which ones are actually going to give you good data about what a child eats, because at certain ages, the child cannot report for themselves, and we found that as a problem in some studies. So.
Hi, Dr. Komenica.
Yeah.
Thanks for coming down. Good to see you again. Nice comprehensive talk. I have a question about race and ethnicity versus poverty. I didn't hear you talk too much about poverty, but it's so inextricably linked to the African American experience, especially in inner cities. Like Richmond is about 80% African American. And how do you separate poverty per se? Can you go to West Virginia and find people in Appalachia that are just as impoverished, and do they have similar problems with weight?
Yeah, I think that's a great point. The population that we talk about, Black Americans, it's a very, very heterogeneous population, and the message about cultural or population tailoring within, tailoring to individuals is a part of that. But I do think that we need to consider people in communities that have low resources, regardless of their race, ethnicity. And in rural areas, there are additional issues associated with rurality that need to be addressed. So I've used Black Americans as kind of a convenient reference point for thinking about a population that can be identified in studies, and you can see different results and what needs to be done. But you're on the right track. We need to look at groups according to the circumstances that create the risk, and then see if we can program to change those circumstances. So thanks for the comment.
Good, thank you.
Hi. A lot of big breakthroughs come when people from very different disciplines interact. Has the systems biology community and the mathematicians, have they really become engaged with the social scientists? Because these are really high-dimensional problems with different types of parameters that you're trying to push together.
I'm not sure that's a question for me to answer. Is Patty still here?
Well, I guess, when you go to meetings, do you see people like that showing up?
No. Well, if it's a meetings on system science or systems approaches, you do. So let me answer the question. The OBSSR had funded a research network called the Network on Inequality, Complexity, and Health, or NICH, and the purpose of that network was to bring people from different aspects of content, health content and systems science together to create some of those marriages and do some of that thinking. And the network did accomplish quite a bit. We'll be had a conference here at NIH February of this year. And so some of that's happening. But when you mention systems thinking and complexity in the usual company of researchers who haven't had an introduction to it, it doesn't catch on quite a bit. So we need a whole lot more of that. And I know the people here are working very hard to get that to happen, but we're not there yet.
Thank you.
Hi, Dr. Kamika. Jack Yanowski, a pleasure to see you again. Wonderful talk as always. We've made mention of some forms of heterogeneity among the populations being studied. How much importance do you think should also be given to genetic heterogeneity among samples being examined in high-risk populations? In other words, you've talked about assessing a lot of different factors, but what about genetic heterogeneity?
I haven't looked into that myself. I mean, I think that genetic heterogeneity is going to be important when you have a treatment or preventive intervention that yields different biological responses. The ones that we're talking about now, especially for prevention, are general strategies that need to be put in place, like the environmental and policy strategies. They need to be in place to enable people to have better control over the eating and physical activity. The reasons that some people will respond better than others may be related to some genetic heterogeneity. So I think we should still continue to explore that as we look at the person-environment interaction, but it's not an alternative to doing these other big picture interventions. And I guess I worry that because public health interventions seem so messy and unwieldy to people that that they will be neglected while the genetic explorations will go forward. So I'm advocating for the public health interventions.
Thank you.
Okay.
Questions in the audience? I'm sorry that we can't turn to people who are watching online and pick up their questions. They're able to see but not speak. We do have another.
I'm just curious why you wouldn't, as long as you're trying to figure out what are the root causes and how to treat them, do something kind of analogous to Framingham. Just pick cohorts out of well-defined socioeconomic, geographic situations, monitor them, let them do what they do, see how they evolve, pay them for their visits, and then you will have a standard set of study set. And then you will have, all you would have to do is pick out 4 samples from the US, from the West, from the East, from, you know, the Midwest or something, and you could do it analogous to what Framingham did, follow people as long as you possibly can. And at least you would have a database giving you data on, gee, what are our risk factors, which is the first thing you need to know before you start all these interventions and complex things.
Right.
No?
Yes and no. You do need to know the causes of the solutions before you start an intervention, but that's not always the same as the cause of the problem. We actually have some wonderful studies that have done what you're talking about. There's a set of studies that has followed cohorts that include deliberately a fair number of African Americans. There's the Cardia study, the ARIC, the atherosclerosis risk in communities, and now there are newer studies that have come out of like the Heart, Lung, and Blood Institute and so forth. And so there are a lot of studies. There's the REGARD study of stroke that have these cohorts. They have not yielded identification of risk factors that will tell us how to intervene much better than what we already knew before. For example, I think it was one of the studies, a detailed analysis, well, it was an intervention study, but a detailed analysis of what were the factors related to people who lost weight during the study and so forth. It's been very disappointing what you can learn. So maybe you can learn something about tweaking an individual intervention, but I think the issue is that in the environment that we're in, if you don't change the conditions that people have for eating and physical activity, you will not be able to avoid a certain amount of weight gain because the platform for risk is across the community. That's why we look at the epidemic. It's not a sudden failure of willpower in the masses. The people didn't just change all of a sudden and then decided to start eating too much. So there's things happening in a society that have to be manipulated, and that's what these interventions are trying to do. You don't get so far when you only manipulate the individual's behavior without changing the societal context, especially in communities where the societal context is less favorable. So we have the observational studies, but that's not telling us enough, and we also have to try to change and see if changing something will generate a response. So it's an experiment in the classic sense of the word.
But if you found, for example, a Midwestern cohort were stressed out because they were in an academic situation, or people from California were stressed out because they were in a poverty-stricken situation, then you would say, gee, these are different, and we're going to attack the obesity epidemic in a different fashion from either, whatever that implies. But I mean, at least you would know how to approach them sociologically, their problem. They might have a different set of solutions to another geographical cohort.
That's possible. Well, maybe there's some ideas there for some studies that will get us farther. I'm certainly open to considering anything, but I haven't. Maybe it's the type of studies we've been doing that haven't been giving us enough of a contrast to really lead to major insights.
Okay.
I'm
Thank you
going
very much.
to I'm going to interrupt at this point and remind everyone that we're going to have a reception over in the library. And I encourage those of you who have questions and would like to chat with Dr. Kumanika to join us in the library for a little refreshment and some conversation. And let's give a big thank you to our speaker today.